The modern eye care center is a pristine sanctuary of precision, intentionally designed to evoke calm, order, and total clinical control. Yet beneath that surface tranquility, a high-stakes biological battle is actively raging deep inside the tissue of the patient's eye. This animation shows a healthy optic nerve slowly deteriorating from primary open-angle glaucoma. It is the classic silent thief of sight. The neural fibers connecting the retina to the brain physically die off, long before a patient ever notices a blind spot or a drop in visual acuity. Our clinical sanctuaries are perfectly engineered to diagnose and treat symptoms. But because this disease operates on an invisible timeline, it actively evades those intermittent 6-month checkups. This photograph captures the first historical pillar of glaucoma management, the reliance on intermittent in-office diagnostic snapshots. The second pillar consists of standard pharmaceutical drops and surgical interventions, all aimed squarely at a single metric, reducing intraocular pressure. While this two-pillar model has preserved the vision of millions, it remains incomplete. A significant percentage of patients continue to lose their sight, progressing to total blindness even when their clinical metrics are officially classified as controlled. The 2026 American Academy of Ophthalmology Preferred Practice Pattern Guidelines explicitly bridge this gap, mandating that clinicians expand their intake to include systemic factors like type 2 diabetes, systemic blood pressure, and axial length. They introduce a third pillar, the integration of high-frequency continuous home monitoring. Alongside this technology comes an aggressive focus on evidence-based lifestyle modifications and systemic health optimization. Preserving sight now requires abandoning the concept of the isolated eyeball. We have to treat the patient as a dynamic, continuous biological system. The 2026 guidelines mandate a highly individualized risk stratification model for every single patient. Hitting a generalized target for eye pressure is no longer enough to guarantee safety. This animation isolates a metric called corneal hysteresis. Hysteresis measures the cornea's biomechanical ability to absorb and dissipate energy and mechanical shock. Here, we see a highly resilient cornea safely absorbing force on the left, while a low hysteresis cornea on the right transfers that mechanical stress directly into the back of the eye. As that stress transfers, the lamina cribrosa bows backward. This structural failure at the base of the optic nerve directly accelerates visual field loss. Alongside corneal biomechanics, the guidelines now emphasize high myopia, specifically an axial length over 26 millimeters, and lower systemic blood pressure as independent critical vectors for disease progression. Mapping a patient's unique biomechanical and systemic profile is the new clinical baseline. It is the only way to separate truly stable patients from those at imminent risk of blindness. Moving outside the doctor's clinic, the patient's bedroom represents an 8-hour daily blind spot in traditional pressure management. This 3D model illustrates a patient in the lateral decubitus sleeping position. Clinical data proves that sleeping on your side or stomach significantly elevates intraocular pressure. The physics are straightforward. Shifting from an upright posture to a flat one alters the gravitational pull on bodily fluids, causing blood to pool on the lower, dependent side of the head. As venous blood congests around the dependent eye, a highly localized metric called episcleral venous pressure spikes. This engorgement creates a physical back pressure against the eye's drainage system, actively halting the normal outflow of aqueous humor through the trabecular meshwork. When a patient buries their face into a pillow, that direct contact compression compounds the physiological pressure spike even further. A healthy eye handles these nightly fluctuations easily, but in a patient with glaucoma, these elevated pressure cycles cause cumulative, devastating damage to the optic nerve. To counter these nocturnal spikes, clinicians are turning to systemic lifestyle modifications. Sleep apnea management and CPAP therapy have become essential tools to prevent intermittent oxygen deprivation to the optic nerve throughout the night. Recent clinical trials demonstrate that daily mindfulness meditation can significantly lower intraocular pressure. Patients practicing 15 minutes of daily meditation showed measurable reductions in systemic cortisol, a stress hormone known to exacerbate pressure spikes. Dietary strategies have moved into clinical protocols, with the use of 3 grams of nicotinamide daily to protect retinal ganglion cells in patients who continue to progress despite stable pressure. Additionally, dietary nitrates support the production of nitric oxide, improving the efficiency of ocular blood flow. These interventions, from sleep positioning to mitochondrial support, form an evidence-based adjunctive framework. They address the metabolic and biomechanical stressors that exist even when pharmaceutical targets are met. From the optic nerve at the front of the eye, the clinical focus shifts to the posterior segment and the macula. Geographic atrophy represents the most advanced stage of dry age-related macular degeneration, a frontier that historically offered no treatment options. These fundus autofluorescence and OCT scans display the physical mechanism of geographic atrophy, advancing irregular borders of dead retinal cells expanding over time. As those borders expand, the corresponding central photoreceptors are destroyed, resulting in permanent, irreversible loss of central visual function. The 2026 guidelines integrate new disease-modifying therapies, specifically pegcetacoplan and avacincaptad pegol. These drugs do not restore dead tissue. Instead, as the therapeutic dosage markers indicate, they actively slow the growth rate of the lesions and stabilize the borders. This runs parallel to the treatment of neovascular, or wet AMD, which now utilizes sustained-release anti-VEGF therapies like Faricimab. Across all these new pharmaceuticals, the overarching goal is therapeutic durability, extending the intervals between treatments to reduce the burden on the patient. Pharmacology has crossed a threshold from merely delaying wet AMD to actively modifying the trajectory of dry AMD. Tracking that specific rate of lesion progression now demands extreme diagnostic precision. This teleconnected home device represents the technological bridge making the third pillar possible: digital home monitoring. Capturing high-frequency data from a patient's bedroom completely fills the massive information gaps that exist between extended clinical visits. Using technologies like preferential hyperacuity perimetry, daily monitoring catches acute disease conversions or exudative recurrences immediately. Detecting those conversions on day one allows clinicians to intervene long before irreversible anatomical damage occurs. By 2026, ocular longevity is secured through a clinical framework that tracks a deeply personalized, multifaceted biological profile. That profile seamlessly combines sustained-release implants, systemic disease management, targeted sleep hygiene, and AI-driven home diagnostics. By treating the patient as a complex, interconnected biological system rather than an isolated eyeball, clinicians are actively intercepting the progression of neurodegenerative eye disease before it reaches the fovea. The progression toward blindness is a manageable outcome, stabilized by clinical precision and the continuous integration of data.